Living Seed Media brings to you God's Word, which is His comprehensive equipment for changing lives. May the Lord impact your heart as you encounter His Word. For further inquiry or counsel, contact Peace House, P.O. Box 971, Boko, Benue State, Nigeria. Telephone numbers 0703 0363659, 0703 7681198. Email address lsmedia@livingseed.org, or visit our website at www.livingseed.org. Let us sit back and listen as the servant of God brings forth the word of life.
We're looking at community health system strengthening. And our first topic will be models for community health systems. Models for community health systems. Our speaker is Professor Chima Onoka, who is a community physician and a health system economist. He holds a PhD in health systems economics from University of London. Currently, he works as the commissioner on the Gates-funded Lancet Commission, working to promote recommendations to low and middle-income countries on how to reform the financing of their primary health care system. He also works as the Chief Executive Officer of CMDA Nigeria. So we want to welcome our brother, Professor Chima.
It's such a, privilege and a wonderful thing to have been here. It is a miracle, when you have miracles that even when you didn't look forward to them for one reason or the other, God just does the miracle. And then, it is obvious what He wants to do. So we are going to speak about models for community health systems. And when we started, there were many things that, that the Lord spoke to us about. And today He has loaded a lot of other things. There was joy in my heart. I was just singing when I heard the testimonies, listen to all the testimonies from BMC. They ministered to me very directly, and I saw that, look, God is doing amazing things. Now, while we go about this, all that we're doing, yesterday I mentioned three things: that we've had a crisis linked to COVID. We also have all kinds of crises in the sector. And then that also have a timed period. All of us, some people are at different stages, but one day we will exit. But then this decade is very important and very important for us. And God has been pushing and speaking about many things, and the people He needs are right kind of people who are battle axes. So the sector is exactly what we are seeing. Ask somebody about the problem in the health sector in Nigeria. It is like an elephant. Am I correct? It's like an elephant. It's hard to know where to begin. It's like having to eat an elephant. Where will you start from? Where? It is huge for everybody. Next slide. If we are going to do it, so it's this kind of elephant that people have tried to approach from different ways. We've heard about primary health care for over 40 years now. We have come up with all kinds of things, all focusing on how to solve the problem. For some people, primary health care means a primary health center. which it is not. But that's what it's about, for lots of people. There are things around the World Health System. And we've studied that all of us health workers have at one point or the other studied something about it because we have rules within it, defined based on the political world. We've also talked about, what are some strategies to solve problems like human resource problems. So the midwife services scheme came up. I'm mentioning these ones that are particular to Nigeria because Nigeria has a way of hearing about ideas from somewhere in the world, crafting a new document for it, and then, and we start running, but they never get evaluated in the real sense of the word. There is some evaluation on the MSS, of course, the midwife services scheme, which UNICEF tried to support. But all that was also to deal with the problems, at the grassroots, pushing midwives there. And we've also had village health workers. It's not a Nigerian concept. It is something that has come from various places. So Nigeria has a cocktail of examples from all kinds of countries. We've also had things like the corps, and the voluntary community mobilizers for different things, still focusing on how to deal with the problems on hand. And then, more recently, there was an attempt to pull the health workers at that level, at the community level, into the CHIPS program for those who have been involved in that aspect. And then TBAs, the patent medicine vendors, they're all playing in that field. Now, how come we've all gone through things like this and then we have remained where we are? I'll try to speak about a few things. But those few things begin with that building. This is one of the examples of primary health centers that we have in this country, focused on a people, on us. Now, primary health care center is meant for everybody, where we can all get primary health care, right? Who is it for? Why is it there? Next slide. Who knows where this is? Anybody? All these pictures are from Abuja. Central Bank, Sheraton, and then the others, the central areas, different times of the day. Now, this is Nigeria from some people's perspective. And sometimes, even in our states, people leave Abuja with mindset and come to our states to try to help us to shape the plan for our people. But this is what, because perspectives matter. So that primary health center, is it for these people? Next slide. Okay, it's for these people in this other slide. Now, this is also a, in fact, locations are within 30 minutes from the city center. These locations are within 30 minutes. And 30 minutes means a lot of people live beyond 30 minutes from the center, depending on the time of the day. But within 15, 30 minutes, you'll find all of these places. Now, you see, the problem is that people that live in that first picture, a lot of those that work for them, nannies, drivers, that come to their homes every day, living, come from these places. So, if there is any problem, if the country is not designed to serve these people, Abuja, even Aso Rock, is not safe. There is nothing like managing a pandemic when you have this kind of thing. Managing an epidemic, there isn't. So if people that are here are not taught about, we can't really move forward. And thinking about them means many things. Next slide, please. We also have this group in nearly every state and the FCT now. Riders that a lot of the bikes have no number. There's no identity. There's no identity. Now, why am I raising this? It appears that we have policies and plans that are meant for people that are really not Nigerians. In fact, that first picture, when people there have problems, they find their way how to solve a problem. What is being designed is not for them. That's at the heart of our problem. And then these ones need getting because they are unique as well. Next slide. So if you look at exactly what is a community, it depends on many factors. It depends. There are various perspectives to thinking about a community. Is it as an individual's community? You start thinking about your own networks, your social networks, your spiritual networks. If you're a health professional, it includes some of those people that call you to get guidance on treatment. That's like your community, an ecosystem around you as an individual. Your discipler, the person you are discipling, that's your ecosystem. And what happens to you and to them affects you. It's a community. But you also have community in terms of looking at it from a social perspective. Okay? So you are linking different things that contribute to your own environment, to your personal environment. You have that from a virtual perspective, especially with the technology issues. So you can have a child who is a teenager who is in your house, and then the person is inside Australia, even though he's in your room, in the room, because of that virtual community. And then from a geographic perspective, the way that we look at things, based on the boundaries. And then it's also important to look at it from a systems perspective. And in this case, it's not just about the boundaries, but the other environmental factors and the relationships between people, and then issues that affect health completely, especially if you also add within a boundary. Our work has actually increased because you can see that even mental health conditions are being influenced, that you're going to deal with, are being influenced by people who are virtual. But the person is right there. And the person's health is dependent on things that are happening from Japan. We have to make plans and arrangements for that. So next slide. And, this is just, it's captured in all of these kind of things that we see as social determinants. The things that we need to think about really, about people's income and all of that, food, both at the personal level and as a group, the working conditions, the development issues, early childhood development. And Professor Mokolu can speak a lot about that, from the genetic part of it to the other factors that shape, the development of the child. And may I add as well to the spiritual issues, because they are determining health is critical. How do you solve the problem of, people having, bad teeth and all that? Tooth decay. How do you solve it? Is it just by taking one out? It is tooth decay is not just I give you advice, you go. Is a lot of times it's connected to lusts, and cravings that sometimes have spiritual undertones. So how do you deal with it? By just pulling out one? You're going to pull out another one. So they are crucial when thinking about that ecosystem around people. So we need to design and look at people differently. And that is really looking at all these people that are gathering, all these people that we meet, from that community perspective, that we're able to define things about these groups, define who they are, all kinds of things about them. And then that influences the service and the system that is in place to make it run. Next slide. But to do that depends on something that is fundamental. And that is around the vision, what exactly we see. We know the definition of the health system. We heard it again yesterday during the keynote speech, which was beautifully packaged. Now, but for us, it goes beyond what is looked at as the health system. For us, we are dealing with a system for whole health. A system for whole health, which I choose to define as, or just explain as, the one that allows us achieve these temporary goals, physical, social, mental well-being, but also helps assure spiritual health as much as possible on a permanent basis. If our eyes are centered on that, then our definition of community will be different. There are many things that we're going to consider as we are setting up those plans. I will also add for things like primary health care. The most recent definitions around primary health care are more complex, but more focused on the assignment. And I'm just speaking about primary health care because it's just that foundation. We've not got it right in the first place. It's a whole society approach to health, that aims equitably to maximize level and distribution of health, well-being, and then it focuses on needs and preferences. Needs like this is a health need they have, but the preferences around when do they need it, those things about timeliness. In a community where everybody goes to market, do you really benefit? Do you really do a lot to them when your services are when the health centers are open 8 to 4? No, you probably need fewer people in the morning during that time and more people in the evening after 4 p.m. till about 8. If that doesn't happen, then that service is not for that population. I was speaking in Abuja, I asked the question. The things about, for instance, health insurance are tied to, it has to be near where you live. And thank God for the questions that came from Lagos. The same thing in Lagos. Where you live, the people come back to that place in the evening. They go to work. So if you connect health insurance, they were asking questions about why is it that people are not utilizing it. I said, when they go to work, should they leave the office to go to that place? Or, if it's where they live, then they won't come to work at all. But it's possible to have a connection with both where they work and where they live, so that whether they're at home or not, the data is the same. They can access the service, and it will not become a disincentive for work. You see how we kill productivity? So those basic things. Next slide. And of course, everybody knows that it is the surest way to guarantee health outcomes. Going in that direction. If the first contact, like our father said the other day, that first contact being timely, makes a whole world of difference, and then it is continuous. You see, we have all kinds of things written about that there's two-way referral in this country. Where does two-way referral happen in this country? It doesn't happen. But we believe that there's two-way because the document is in our facilities and it is in Federal Ministry of Health, the basement, where it gets packed. Because it's in this book, there's two-way referral. It doesn't happen. Why don't we just settle down and plan the one that can work for us? Next slide. So the range of services for that community system has to be packaged, taking into consideration all the kind of possible health issues that people will have, this defined population, their size and density, the geographic boundary, what can happen in such places, and then the level of economic development, infrastructure that is available, the quality and quantity of health resources, human resources for health that they have. And then in attention to national policy, I say paying attention. I don't mean adopting it wholesale. If something is not working, what you now do with it is to just see that you're not breaking the law. But it does not restrict us from adjusting our services to what will work. Whatever document, I've been privileged to see many documents. Next slide. And then, so I've spoken about some of those, how designing it, but the service, the framework, there are many all kinds of models. Because of time, I just want to focus on this. And this is something that is, it is possible to have the medical centers, and like I said, I was so happy to hear presentations from BMC. And then the posts, and in between are many things, which to this center, which I call the facility, you now have those outreaches. Outreaches in a way, of course, that there's both a push and a pull. Push, I mean that the outreach is a place where you can take some things out too. And pull, meaning that from that location of that outreach, that there are specific problems that you can bring back to the trial place. And then, of course, the community posts and the issue of the household giver, caregiver at home, starting with the mother and father, and then the other people that are there. So when that center is there, permit me, and I'm not just speaking about, we've spoken about what is existing. I'm speaking about everything and how we can also push things. So ultimately, you have real networking disunits, reasons that include personnel support to real data that can be used for action. And personnel support, I mean, it is possible that when we build things, the kind of things that, I imagine from all of our lives, that just the way we have BMC, that it's possible that that network is the one that has a radiographer, or let me say, a histopathologist that will analyze the results. But in these places, there's somebody that can at least make the slide and upload. And that person who is at the center there is committed to analyzing it, or is a pool of people who will do an analysis. They've committed their time to it. They are doing something wherever they are, but they are part of that network that they sign up to it. Just like there are many people who are in all the viewing centers currently. There are many of you that have the capacity and the potential to be doing certain kinds of analysis for BMC and other similar places. That can be a better use of time while you're doing other things. It's a contribution because we know the challenges around those things. It's the same thing for any of all the areas. But that's the kind of thing that happens with that network. Next slide. And I also mentioned the community centers, but community centers as well, in a way that if somebody registers for healthcare at a health post, now that's where it now differs from the kind of thing is different as well from what you have in government. The person does not have to go and do another registration at the center. The person has already registered, whatever that is for. And if the person work catches him at a place other than that primary place, he is able to go to this center and also have it. And let's not just think that these are highfalutin. Even the smallest practices and groups can set it up. And then those places are places that health is only a lead factor. Every other thing can happen. People can find opportunities to express the visions in their hearts in all kinds of ways and find expression. I mean, if children are gathering in some places because they are coming with antenatal, that's already a group where children can be raised. For the person who feels that his burden has to do with raising children. Next slide. Beyond the community part is what I would say as the broader community network, because it is important that those systems are supported. So this is a broader system of support, a network around it, which includes people that can do one thing or the other from anywhere. We've talked about the services, the resources for training as well. Some people can sign up that for BMC and other places, your interest is just some of the things that are being talked about, like training mothers, training some other people, training some community health workers, that you are available as well to provide training. Our brother that spoke at the that spoke about diabetes part was so practical. I was so excited. That is a teacher, complete holistic teacher. They can teach even babies. So that network, we can all be part of it. And it's the kind of thing that will drive a lot of real changes. Data as well, we do need it very seriously. And then I've talked about the health facility network aspect. And then a network of pioneers and leaders, people who really feel they can do something about it. And when that happens, and our father spoke about it earlier as well, people who are ready to multiply models, people who are ready to run with models. And we've seen a typical one here in BMC. Such networks, and the Lord will help us. Then support teams that are everywhere as well. Next slide. I'll try to put this together. So some of the steps are, of course, beginning by knowing our community and engaging with them on what's best. We can't run away from that if we are looking at things from a community perspective. And then having a comprehensive plan that deals especially with contingencies. Those who are wise make arrangements for their weaknesses. I mean, I personally, when I'm trying to engage people, I don't, for certain things like research, it's people that don't understand it that will go, and a doctor will carry 3 other doctors, the same department, and load in the same research. That's not how we do it. You make arrangements for your weaknesses. So if you are strong in one area, why are you going to carry 2 other people that are still strong in that area? So making arrangements for those weaknesses, and then going beyond healthcare, which I mentioned, to education, to other aspects. That health system is necessary as a lever for all the other social determinants. And of course, remember the definition of health that I gave. It's a lever. It's a lever for that complete vision about the health system. And finally on that list, giving feedback. Where you work, when was the last time that hospital, Benue State University Teaching Hospital, when was the last time that you called the people that you should be serving to give them feedback? It's not done because the basis is not community. It didn't start from a community perspective. It happens in a number of places. I was in London when, like, University College London, they came to London School of Economics and Tropical Medicine to give their annual reports. And there are people there to query the results that they are submitting. Why is the output like this? It's an economic environment. Why is the output like this? Because we had all been studying efficiency, hospital efficiency, all kinds of things. So we use them to test how much we have understood our lectures. All these facilities should have a time for that. And they are the kind of things that we can drive because our mindset is community-based. It's a community we are looking at. If we can't give accounts, we are not serving the community. We don't care about what they care. We really don't. And that's our whole picture. They can't hold us accountable. So ultimately, many things. You'll be wondering why this horse is still sitting down. It's still standing there. Maybe it was tied to this pillar for weeks. And when they removed the pillar and put it on the chair, it still felt that it's still there. We can't change anything except that paradigm shift is first from our minds, about our minds. We can't. And that's why, I want to repeat that scripture again in Romans 12, verse 2. It says, let's not be conformed. Let's not be thinking that the solutions or ways of solving things are the same as what we see when we gather together with all our colleagues. No, there is something unique about the people that are carrying the Holy Ghost. If it doesn't come from there, praise the Lord. You see, like this strike that is going on. So people wake up. I said, look, that they've exhausted all the... I said, what do you mean exhausted all the plans? Where are the ones that came when brethren sat together? That will keep insisting that is a sword that has to be used to kill Goliath. There is a stone somewhere. I believe it. It can't just be the sword. The sword can be useful. There is a stone somewhere. Even if I don't see it today, what I will not do is to believe that there's no stone. There is a stone. There's something unique when brethren gather together in unity. So let God transform us. That verse. Let God transform us, transform you into a new person by changing the way you think. Then shall we know his will, and then also know how good and pleasant and perfect it is. If that doesn't happen, we cannot understand and appreciate how good and perfect and pleasant it is. We can't. So we need that paradigm shift, like I've also mentioned, from just thinking about health system to a whole health system as what is driving us for setting up systems. And the next slide. And from hospital mindset, we've been framed with a hospital mind. And that hospital mindset It's like you're sitting down here for people to come. I open a hospital and I'm just waiting for people to come and see me. That's the mindset. That's what I call the hospital mindset. To the community-oriented one, where we actually we take first steps to get to know the community. We are struck with the hospital mindset of waiting for people instead of going to them, or having people at our mercy rather than seeing that we are sent to them. You see, this issue of sending is the same problem that is happening with, all of the mobility that is happening. So somebody is in what do you call it, Aba, and he feels he just has to move to Lagos for better conditions. That person's head is wired that it is conditions that make things work. No, it is first of all whether there is a call from Macedonia. I am sent to people. So my just waking up and saying, okay, I'll move my practice from Aba to Lagos and I'll be doing well, is missing the point that people are sent because there's a community that they need to serve, that God is sending them to. And then, that their views don't matter, and the issue of professionals at work rather than a people serving a community like we heard about BMC. Next slide. So eating the elephant is a community affair. So basically, if you look at your problem and your plan was initially to go to hunt a squirrel, and you step out and you realize that that forest is elephants that are inside there, the first thing you do, if you are wise, is to go back and find your community and find the people we've been discipling and find the people that we understand each other well before going back to that place. And then other things follow from there. It's a community that can eat an elephant. But please don't eat an elephant. There are not many that are left in our world now. Next slide, I think. So that community approach really makes us to think about work as a call, and then the services that are needed. It's a comprehensive range. And, we need to have courageous plans, as I'm sure that's what is happening like in BMC here, and it can happen for wherever you are, to think about the community from that holistic perspective, as if I am the only one, as if this is the only facility in Boko. This is the only facility in Lagos. And I am working with that mindset, and I'm designing the community plan based on that, especially once I define the geographic area that I want to reach. I'm working with that mindset that this is the only one. There can be others, but this my own is the only one. And then I make plans for that. We are the government. There is no government that we can talk about, because the right to governance, to being government, is a right that in real terms belongs to us. So we're actually superior governments in those communities that we are looking at. We're actually superior governments, and God will help us. And if we're going to do that, really engage with it, brethren, some of those things that we have heard, many things, here are things that must be fundamental. Like seeing the place as government, it means that we also need leaders. And every one of us is called to be the leader for change. And things that we have heard, remember when our father shared things about the leader, he mentioned 5 things that have always stuck in my head. The resourcefulness of a leader, the resilience of a leader, the resoluteness of a leader, the relentlessness of a leader, and then the responsibility for leadership. But we really had those 5 points. And They are the kind of things that are needed in times like this to engage communities and to bring about change. And then I want to end by saying that at the end of the whole thing, let's remember that nothing is impossible with God. Emmanuel, we made contact with him early this year in one of those areas that I'm talking about in Abuja, those slum areas, those pictures that we saw. And he had a broom that had got stuck in his hand. His mother beat him with anger, and the broom got stuck. So we called a number of the brethren. We came, tried to use the health center there. It didn't come out. It had lasted 3 months. So the place was big, swollen. It was hidden, searched, find the pediatric surgeon. Then we now went to the hospital. After that search, this boy was going. And his brother had died before. He was the only son of the parents left. And the father, I even went to the house. The father was, the way he was looking at the man, knew that if this boy died, that man will kill that woman. They now say that at one of the hospitals, 3 hospitals in Abuja, we needed to pay like 100,000 for the next, if they are going to touch him, for this broom. We went, spent on investigations, it was located. Then the night before the thing, we have been praying, Lord, this money can be invested on something. The night before, popped up. It was pulled out. What was it? God is still working miracles. And if we go from a community perspective that understands our limitations in the places we walk, and some of these people that we drive away that can't pay, there are things that God can do when we trust him, because he knows that the resources for that one is not there. He will make a way. God bless you.